The final session of the afternoon, I'm really pleased to introduce you to Carole Cusack, who has come all the way up from Wessex LMC and has been very much involved in the CQC pilots that have taken place to date. So without further ado, I'm going to hand over to Carole. Thank you.
Okay, thanks very much. Okay, it is late in the afternoon, so we'll try and make it snappy, but I will answer all of your questions, I promise. Okay, so basically, you're all registered now, aren't you? Good-o. And you've got your registered manager in place. It's probably one of your GPs, and that's probably the last thing you'll ever do with being CQC'd. It's all down to you guys now, okay? All right, so I'm going to talk about registration compliance. I'm going to talk about the pilots that we held in Wessex between 17th of July and 17th of August. I'll talk about what happened at the feedback session on the 29th of August and what lessons were learned. And in actual fact, CQC, yesterday afternoon, quite late, issued the report from the feedback sessions. I held my breath as I read it because obviously I've been talking about this for months now and was terrified that suddenly something would come out of the feedback that actually I've been telling differently. So far, I haven't found anything, so that's good. Now, I do apologise. I can see one or two faces in the audience that have probably heard most of this speech before. You can either go to sleep or you can listen, and if I say anything wrong or if I've changed anything I said to last time, I don't want to know, okay? Because my self-esteem will plummet. Okay. Right, okay, so, did that go the right way? Yes. So, regulated activities. Just want to clear up a couple of anomalies on this one. You might all be dead clever and have got it right, but in some areas, they're getting emails back in particular about maternity and midwifery services. When your 28-day window comes, or if it's already gone, you have to put in that you do provide maternity and midwifery services. Now, I know that in the majority of cases, your GPs have been de-skilled because the midwives took over, didn't they? They keep trying to hand it back a little bit now, but they've taken over and they're the skilled people. However, it is in your core contracts as an additional service. So if you put that you don't provide that service, you're in breach of your contract unless you've opted out. And if you've opted out, you've had your global sum abated by 2%. So I would suggest that you all provide that service. Even if all your GPs ever do or your nurses do is take the blood pressure of a pregnant woman, you provide that service. And with family planning services as well, the only service that is called a family planning service in terms of CQC is IUCDs. Everything else either comes under surgical procedures or treatment of disease, disorder and injury. But apart from that, I'm sure everything's ever so clear. Oh, keeps going too fast. Ooh. I think it's gone massively too fast for me. Ooh. Okay. Essential standards, as you know, set out in 28 different regulations. Now, I normally at this point pick up a tome that's about that thick, and then people have caught me out because you can see I never read it because it's too thick, it's information overload, and it's not what you need. What you need is your common sense and what's actually happening in your practice, and most of you will be utterly and 100% compliant almost already, if not very, very soon. And I promise you what happened at the pilot inspections was actually no worse than any other inspection you've ever had for QOF or anything else. And in fact, in some ways, it was better because you felt that they actually were on your side, dare I say it. CQC, if you remember this mantra, all they're interested in is, are your practices safe for yourselves, your staff, your GPs, nurses, and your patients? And do your patients get what they need from you? That's it. That's what they're looking for. So they don't go into huge, great amount of detail in some ways like other organisations have. Oh, I'm frightened to touch this thing. Okay. Pre-inspection. This is the stuff that CQC do and try and find out about you before they come anywhere near you. And during the pilot inspections, they used QOF data. Unfortunately, it was the 10-11 QOF data, so it was well out of date by the time they were doing the inspections, and a lot of practices felt a little bit upset about that. particularly as they used RAG rating, the red, amber, green. So what they did is they went through the various domains of QOF, and they had a look to see where you were in terms of, you know, thresholds. And if they could find some that you hadn't quite reached the threshold, they put that down as one of your areas and put it as a little red block. So the pilot practices got these reports that had loads of big red blocks on, just a few green and amber, I think, just to make them feel better. When we questioned this and said, why are you doing that? It was basically because they've got very little else on you, and very little else they could find out about you. But I'll talk a bit more about that now because I know a bit more about what they're doing now. The interesting thing was that at a few of the visits I was at, the inspector would ask about one of these red thresholds, and the practice manager could basically have said anything they liked. Oh, well, it's because Mickey Mouse lives up the road, and the inspector would have gone tick. And the reason for that is that they are not trained to understand QOF, and they're not going to be trained to understand QOF. So you can do what you like with that one, but they're going to use it. They're just not going to understand it, okay? They are looking at hospital episode statistics, and we keep asking them why, and we're not getting an answer. We don't know what that could prove. You know, if you're an outlier of some sort, you can justify that. I suspect their training on that will be the same as on QOF. Patient surveys they are very interested in. And of course, last year's was the last year that you did the sort of main QOF, GPAC or CFEP survey. So they did use that for the pilots. Now, as Peter's just said, your individual GPs are going to have surveys for their appraisals, but they don't need to share them, and they certainly don't need to share them with CQC unless they want to. Patient surveys then, therefore, the only one that you'll have is the one that you'll be doing through your PPG DES. So they will be interested in that, okay? So be warned. And because of that, unfortunately, I think the pilots drew their attention to the fact that you have to publish that on your website. So they suddenly realised that practices have their own websites. So they've started looking at that now, which they weren't before the pilot. So they're starting to look at your websites to see what your practice looks like and how you sort of put yourself forward. They also look at NHS choices, and they will definitely look at that, and they print off any comments that patients have made about you. Now, don't worry, because we went through vexatious patients and the fact that in a number of practices you can see, you know exactly who's written what in that comment. What CQC are interested in are two things, really. If you get the same comment again and again and again, what are you doing about it? Or if you get something that you've ignored. So they want to see that you've actually responded to your patients, that you're taking note of what they say. So if somebody puts, I couldn't get an appointment and the receptionist was rude and I'm fed up and you're a practice, all you've got to put underneath is, oh, I'm so sorry that you had a bad experience. We'd like to try and talk this through with you, so please contact the practice manager to make an appointment, Mr. Anonymous, and we'll certainly sit with you, we'll look at what the issues are and see if our processes need changing to resolve that. CQC love that, okay? They're happy as long as you're taking note and you're trying to do something about it. Obviously, if it's more specific than that, then you would answer more specifically. But in the main, just invite them in. They never come because cowards always go anonymously, don't they? They're also starting to look at various information from the Health and Safety Executive, God knows what, RC, GP, GPES and GMC. Basically, they're scratching around to know what information to pull out about your practice. They're having real trouble with that, and we're helping a little bit. Okay, so the inspection itself, it tends to be just one person. Okay, it'll be one inspector who comes in and presents to your reception and will ask for your nominated individual. So it's not your registered manager, your nominated individual, which is probably going to be you guys. So it'll be the person that's having the day-to-day contact with CQC, the one that's put themselves forward to get all the information. And then when the practice manager, or if the practice manager's not there, they will ask for whoever is available. They often ask for a tour of the building, mainly just so that they can get a feel for the place, they can see where the consulting rooms are, treatment rooms, things like that. But they're not particularly interested in having an in-depth premises type inspection. They don't do that. They don't go around and rub their fingers over shelves and things like that. They don't do that, okay? If you greet them with arms full of policies and procedures, they'll have a fit. They will not want that. They really don't want to look at lots and lots of policies and procedures. What they do as part of their questioning of GPs, nurses, HA staff, yourselves, they will ask questions and they may well say to you, do you have a policy on that? Now, what we found is if the practice manager said, oh yes, absolutely, would you like to see it? The answer was no, thank you very much, that's fine, tick. If the manager went, think so, can I see it please? Okay, be confident. You might get away with it. Personally, I'm not much of a gambler, so if I haven't got a policy, I have to say, oh, I haven't got one, I'll get one. And it just becomes part of an action plan. They're not going to find you non-compliant because you haven't got a policy, okay? As I say, they spend a lot of time talking to staff and to patients, and what we found with patients was it's far, far better for them to talk to them after they've had their consultation. Now, two reasons. One is that if you interview them before, they get very nervous about missing their slot and missing their appointment. So they get quite agitated and they sort of get a bit annoyed with the inspector. And that's not good. So if they're annoyed with the inspector, they're annoyed with you. The second reason is if they've seen the doctor or the nurse first and they've been asked if they would like to speak to the inspector, withdraw that if it's been a bad consultation. Just say, don't worry, they don't need to see you now. Off you go. So, you know, you can sort of work that out for yourself. The other thing that CQC do, and in the report that came out yesterday, it wasn't very clear because they said when they look at your website, they will decide from that who they want to speak to. Now, in the pilots, because they don't want to disrupt your working day, they ask the manager to give them access as and when possible to a doctor, a nurse, a healthcare assistant, staff in a group during lunch break maybe, or something like that. And I can't see why that would change. So it may well be that when they look on your website, they might say, there's 7 doctors, we'd like to speak to 3 of them, but you choose. So, you know, if Dr. X has come in a grumpy mood that morning and you know he's going to give CQC hell because he's fed up with it all and he's had enough, he's too busy. He can't see anybody, he's full up, he's got loads of extras, and then he's got home visits, okay? So you choose who they're going to see. The trouble with that is you haven't got masses of notice before they come. Your notice period, and I was going to go on to this later, but we've just had it confirmed, your notice is going to be 48 hours. During the pilot, some of the visits were unannounced. Some were 48 hours, some were 4 to 5 days, and some were 10 days. We didn't have any of the 10-day ones in Wessex, but we had quite a mixture of all of the others. The unannounced ones we felt didn't allow for a practice manager sometimes to be available, and that actually did happen. 2 of the visits I went to, the practice managers, quite rightly, and priorities, correct, were watching the sailing down at Weymouth. What can you say? I think they did the right thing. And as CQC say, you've got to run your business without the practice manager being there sometimes anyway, so what does it matter? When it did matter is when they did outcomes like recruitment and things like that, only the practice manager had the access to the files. So there was a bit of anomaly there. So they agreed not to go for unannounced. 4 to 5 days, unfortunately, your colleagues who fed back said, oh, I was ready to top myself, because they spent 4 days fretting and trying to put things in place. So 48 hours was felt, you can sort the right people out and things like that, maybe change a few diaries around, but other than that, you just get on with it. Okay, after they've done all their talking and everything like that, they'll give some brief feedback at the end of the day, so they don't go away with you thinking, how did that go, they will actually give you some feedback, and it can be to you, to any of the doctors, nurses, HCAs, staff, anybody you want to be there who's available, and they'll just tell you basically how they felt the day went. They said during the pilots that they would take between a half and a full day. Every single one took a full day. They arrived somewhere between 9:30 and 10 in the morning, except for when they got lost. And they left around 5:30 to 6:30. And they kept going all day. Okay, they had a very brief lunch break. In fact, the first 3, I was so desperate to get them out of the room so I could actually look at their paperwork. I mean, I did manage it on the 4th one. We sent them down to Sainsbury's to get a sandwich, and they left all their stuff, so that's how we know what documents they use, and I'll talk to you about that in a minute. Okay. I did tell them afterwards. Look, they said they're not there to catch us out, okay? So if they're not there to catch us out, they need to be open and transparent, as we were afterwards. Okay, involving people. They are really, really keen to talk to other people about your practice. So they are going to be quite keen to talk to either your chair, vice chair, members of your PPG. And where they are virtual, they are likely to ask you for details so that they can either phone or email somebody in your group. So just be aware of that, and please make sure your PPGs are aware. They are going to talk to the local involvement networks, which are going to sort of be part of Health Watch shortly. Now, we sort of said to them that the local involvement networks at the moment really have very little to do with general practice, but they tend to be the ones that work with PCTs, but they have said that the links and the Health Watch people are going to have far more to do with you. God help us, we don't know how yet, so they will be involving them. And they also say they'll be involving the overview and scrutiny committees of the local authorities. Now, again, the only times I've ever come across an OSC was when a practice wants to close a branch surgery and the OSC gets all upset because, you know, that local councillor happens to live down the road and he doesn't have to catch a bus. So he gets on his high horse about it and then starts moaning. Other than that, they really don't know who to talk to. And some of those organisations are going to know absolutely nothing about your practice anyway. They're struggling. Okay, so talking about the experience of the actual visits themselves, as I've just said, they do take a whole day. They are saying as they get more slick at it, they may well be quicker. I can't see it, to be honest, because they only did around 4 or 5 of the actual outcomes. The problem is you don't know which outcomes they're going to do till they get there. It is one of the first things they tell you in the morning. So once they've met with you, they will say to you, we're going to look at outcome 1, 3, 9 and 7. They are still saying in the report that came out yesterday that they will do a minimum of 5 outcomes, which tells me they won't be able to do them as in-depth as they did at the pilots. If I can just give you an example, the sorts of things they did is if they were talking about safeguarding, they would talk to a doctor about safeguarding and say, what training have you had? What would you do? Do you know who your local representative is? If your doctors don't know that the safeguarding lead is based at the local authority, make sure they do know. It's nowhere else. It's the local authority that are the leads on safeguarding. Contrary to popular belief, CQC are not interested if the GPs have done level 3, 2, 25 or 7. They just want to know that they understand what they have to do in a safeguarding issue and that they make the right notes in their records. So it's really important that they document everything to do with safeguarding. They'll have a very similar conversation with nurses and HCAs and with staff, but they'll change it slightly. So when they're with a group of your staff, they may well say, okay, you're the only receptionist on, it's the end of the day, and there's a mum in the waiting room with a little kid, and she's beating hell out of him. What do you do? Your staff are only trained to work as receptionists. What they would say in that situation is, I wouldn't do anything personally because I'm not trained to deal with that situation. However, I would immediately go and report what I had seen to the practice manager or to the doctor or to the nurse, whoever's in the building that is senior to me, and I would expect them to do it. As soon as they say those words, CQC, go tick. Because there's the awareness is there, whether you've got a policy, whether or not they, think they should intervene, as long as they know that they mustn't ignore it and what they do about it is absolutely fine, okay? And that also goes for your HCAs. We had one HCA that was interviewed, and she did phlebotomy. And the CQC inspector said to her, and I had coached her with those words, said to her, if you were taking the blood of a child and you noticed lots of bruising, what would you do? And this HCA looked her straight in the eye and beautiful, she said. Oh, she said, I wouldn't tackle the mum, that's not really my remit, but I would go and tell the nurse practitioner or the duty doctor or the practice manager. The CQC said, and what would you expect them to do? She said, oh, well, they know how to handle it, they know who the safeguarding leads are, and they would pass it on, but I would check later. And the CQC lady went, that's very good, excellent, tick. And this HCA then went, hey! I went, no! So tell your staff, when they use those words, keep a straight face. Okay. So, like I say, they did keep true to the word, not lots of policies and procedures. As I say, do have them there, or have them available somewhere in an electronic file, but don't produce them unless you're asked. And the practices and the 21 that we did were asked for very, very few, okay? When they talk to patients, they will ask you to provide a room for them. They did try during the pilots talking to small groups in the waiting room, and that didn't work. Patients were uncomfortable. It just wasn't right. So if you've got a room available for them, and they can be asked at reception, will you be prepared to talk to the CQC inspector after your appointment? Or if you have a touch screen, then ask the doctor or nurse just to say, look, CQC's here, would you mind talking to them afterwards, and then sit them in a certain area or wherever, and CQC will collect them. They do quote patients in their report, not they don't name them, but they do put quotes in from patients. So it'd be lovely, wouldn't it, for us all to put things around saying, my practice is wonderful, my doctors, I love it. You can't. You're not allowed to teach them or train them. Just, and in 48 hours, you're not going to quite get the right ones there, are you? But, be selective. Be selective when you're saying, would you like to talk to CQC? It was very rare that there was any adverse comments from patients. In fact, I think there was only one, and that was something like, oh, they haven't got their own car park. It's a bit of a pain. That was it. Can't do anything about that. CQC didn't give a monkeys. Okay. Like I say, at the end of the day, they'll give some verbal feedback. After they go away, they write a report which is with you within 10 working days. You are then given another 10 days in which to respond. Your response can only be in terms of accuracy. So if on the day they say, have you got a policy for this, for instance, and you go, no, they might say in that report, we would suggest it would be a good idea to have a policy in place. If you write that policy the day after they've gone, that doesn't affect the report, because all you're checking for is accuracy on the day. And often there were issues with terminology. We do use different terminology. Is that another 50 quid? Is it mine? So you can only go on accuracy. So whatever they've asked you to do or suggested you do, you can't change it there and then. You basically have to do an action plan or a report, as they call it. And then once you've had your 10 days, they'll publish that report on their website. Okay? So if they've found you either non-compliant or made any suggestions about what you might like to look at, because they're very clever, They are not read. They don't demand you do anything, unless it's a fire thing, then they do. But otherwise, they just suggest it. And then they say, could we have a report, please? Which basically means an action plan. So you need to put an action plan together saying, these are the things we need to look at, this is how we're going to look at it, this is what we're going to produce, and this is by when. Once you become compliant, notify CQC. They will take up to about 3 months to respond, unfortunately. But once they're happy that you are now compliant, they will change their website. It's unlikely you'll get another visit. It will all be done either by email or phone or report. On odd occasions, there might be another visit, but their capacity is such that they're not going to be able to fit them in. Okay. These were the major themes that came up at most of the visits. So even though we know they're only going to do around 5 outcomes, what we don't know is if there's going to be like 3 they do every time and then 2 others, or whether it's going to be a different 5 or 6 each time. Because they're saying now they're only going to visit you every 2 years, it's going to take about 6 or 7 years to actually get through all the standards. So we suspect they probably will concentrate on the major themes in the early visits and then do the softer ones later on. But we don't know for sure, so unfortunately you're going to have to be ready. Safeguarding was a big one, and we've already mentioned that. Infection control's a big one for them. What they're interested in is they don't care if you've got carpets in your consulting rooms. In fact, they understand that patients, when they come to the GP, want to be comfortable, want to feel, you know, sort of at home and everything. They don't want to come into a clinical setting unless they're having some actual treatment, in which case, yes, your treatment rooms do need to be of a certain standard. But if they're not now, as long as you've got a really good, auditable cleaning schedule in place and you follow it, CQC are happy. They do not expect practices to spend oodles of money putting in elbow taps and changing the flooring and everything else. They do expect you to have risk assessed and you be able to justify why you've done or why you haven't done anything that's there. One of the PCTs that I worked in, they used to go along to practices, and if there was open bookshelves, they'd say, right, you'll have to get those put into cupboards because they're dusty and they're awful. Not true. That is not the standard that CQC expect. And in fact, I tested this out at 2 of the visits, and I took them over to a bookcase in a GP surgery and said, can you have a look at that and tell me if you find anything wrong with it? They found an out-of-date BNF. And said if a locum uses this room, they might get things wrong. That's got to go. And as long as we chucked it in the bin, they were fine. Okay, so your soft toys in your waiting room, you don't have to change your chairs from cloth chairs as long as they're on your cleaning schedule. So when they're out the room, we had a look at what they use. And they use the NPSA, the National Patient Safety Agency infection control document. And at the back of that, there's a beautiful cleaning schedule. Okay, so they use the standards in there, but they use them proportionate to primary care. So don't please think that they're going to look at you in the same way as secondary care. They're not.
Sorry, can you just repeat that?
The NPSA, National Patient Safety Agency. If you get stuck, I've got it on my website, and the address is at the back of your handouts, or I can send it to Rachel and Carl, and they can put it on theirs. Okay? Recruitment processes and procedures was also quite high on their agenda. They were very keen that you know who you employ. So they want a photo ID in everybody's personnel file. Smart cards. Just photocopy your smart cards. Okay? It's easy. Don't make it hard for yourselves. All right? And they also, where you've employed staff in the fairly recent past, they would expect to see the job description, a person spec, how you advertised, how you scored, and things like that. They're looking for skill mix to make sure that you've got the right sort of skill mix to do the job. They're also looking to make sure that there are training PDPs and things like that in place to make sure that your staff are trained. And they will ask your staff, when they meet with your staff, The question every single time, every group was, do you feel supported in this practice? Do you feel you are trained properly to do the job you do? Okay? You tell your staff, you put it in your contracts, you say anything wrong, you're out. Okay? Mr. Acas? Okay. Just make sure your staff are aware that they will be questioned, but they needn't worry about it. It really is quite painless. Okay. Now, at this point, we ought to talk CRB checks, oughtn't we? Okay. Still not clarified. What we think, and in the report yesterday, it was still very woolly and very disappointing. They are still saying that you have to risk assess and justify who you CRB check. Which isn't very helpful. So we're doing a little bit more work on that, and I've got to call into CQC because they did put out a little bit of guidance a while back, which basically said GPs have CRB checks when they come onto the performers list. So as long as they've got a GMC number, they should be fine. Nurses will need a CRB check. HCAs will, because they work behind closed doors with vulnerable adults and children. When it comes to admin staff, yourselves, you have to risk assess, am I ever in a situation that? Now, we did have some problems with one of the CQC inspectors who thought that absolutely everybody, including the cleaner and her cat, should have a CRB check because they can see, they have access to medical records. We see that as a confidentiality issue and something that's in their contracts anyway, and a data protection issue. So we're still arguing that one, I'm afraid, but they have said that they will come out with some more definitive guidance shortly. Bit disappointing. The final thing I'd say on recruitment is inside your GPs and your nurses' folders, record their GMC or NMC number and the date it expires, because they have to renew every year. Make sure you know and that you've got a process in place to make sure that you update that annually. They were really, really keen on that. Okay? The next issue was about consent. They wanted to make sure that consent was gained where required and that at least the doctors knew how to assess under the Mental Capacity Act that whether or not consent was viable and whether it was doable, and that it's documented in the records. Meds management, that's all to do with prescriptions being maintained safely. I think my chief exec sent something out a little while ago about this because they don't like doctors that leave smart cards in machines and prescriptions in printers and leave the room with the patient sat there. So it's all stuff like that, and make sure your fridges aren't accessible to the public, etc., etc. So, outstanding issues at the moment, CRB checks we just talked about, the type of data that you're going to get. They gave our pilots what they call the QRPs, the quality and risk profiles, before the visits, but they talked about not giving them in future, and we've said, why? If you're going to be transparent about this, you're not trying to catch people out, we should see it. So we're still talking about that. Notification of the visit, as I've said, is going to be 48 hour. The only concession we got was that it probably, I'm not going to say definitely won't, but it shouldn't be a Monday, and it shouldn't be the day after a bank holiday. They did accept that. We did talk about the availability of the practice manager, and that's the 48-hour concession. So you guys, you never have a holiday. Okay? Number of outcomes, we said, be about 5, possibly more. Frequency, they're talking every 2 years, but I did bump into a colleague from the department the other day when I was in London, and they said they're going to be lucky if they make you every 5 years with the capacity they've got at the moment, but you can't rely on that. So we'll just have to wait and see. Interpretation and terminology, do be careful when you're saying anything that they do understand what you mean, because they said things to us that we took in a different way. Because they're trained generically, so they're not trained just to do general medical practice, they're trained, and they could be doing a nursing home one day, a dentist in the morning, you in the afternoon, and a care home the day after. They're trained on the essential standards, not on general medical practice. So often they'll use words that we don't understand and vice versa. So just be careful on that. Access to patient records. At the moment, their legislation says that they can look at anything without consent that they want to. and that includes all patient records and all your staff records. Again, during the pilots, they definitely got consent, but they don't have to. Their legislation overrides the need, and that's still being talked about because we're all quite precious about that, aren't we? And then finally, at the moment, if you haven't seen it, the consultation is out on fees. So not only are you going to be inspected by CQC, but you are going to pay for the pleasure. Okay. At the moment, the consultation is saying that if you have one location, and by a location, remember, their terminology, that's one registered list. So you can have 2 or 3 buildings. If you've got one registered list, you'll pay one fee. And that fee will go up. It's not proportionately, actually, it's dreadful. It starts off at the moment, they're talking about a single-hander would pay about $550 a year, up to practices of over 15,000 paying £850 a year. So the big practices are probably going to be able to afford it. The little practices are really squealing. And we know the GPC is still talking to the Treasury. We are one of the very few medical providers that can't put their prices up to cover that cost, like the nursing homes, the care homes, the dentists can. But I don't think they're going to get anywhere. The Treasury is saying it's down to that. And what you've also got to read between the lines with CQC is they say that if they set those fees at that rate, that will cover 50% of their costs, which tells me that in 2 to 3 years, it'll be double that because they'll need to cover 100% of their costs. So, you know, not a lot we can do about it, but you can comment. You can go on their website and comment, and please do. The consultation's still open. And that's all I really had to say. So, questions?
Hi, my question is, I've got 2 sites.
Yes.
How do I know which site they're going to go to? Because I certainly don't hold the records for the staff at both sites.
Right. What they will do is if you've got more than one site, they will make the appointment at your main surgery. Okay? They may not even visit your branch surgery, but you're not going to know that until they arrive. So during the pilots, we had one practice that's got a main surgery and 3 branches. They visited the main, they went over to the branch for about 2 hours and then came back and spent the rest of the time at the main surgery. But they are happy to be guided by you. If you say, we don't hold that here, we hold it somewhere else, they'll either say, that's fine, or let's go, or I'll call you. You go to that site tomorrow, I'll call you there and we'll talk some things through. So they will manipulate the visit to suit what's needed.
I work for a single-handed practice, so what happens when he's on holiday and I get 48 hours notice that they're going to come and visit?
What they will say is you still have to run your practice when your GP's on holiday, single-handed or not. So your locums will have to be pretty well trained, but not to the same extent, because they're not going to be your safeguarding lead or your this or your that, but they will need to know about safeguarding. So if you haven't got a locum pack put together that you can hand over with lots of things in that they need to know, I suggest you get one. And I don't know if you've got one on Beds and Hearts, but we've certainly got one on our website you can get hold of. The feedback is coming out on our website. I keep doing that. I'm so sorry. I feel a bit uncomfortable. But on our website, and I have been sharing it with other LMCs, there's all the feedback reports from all the practice managers that had visits. The CQC feedback report is going to be on their website this afternoon. And there's a link going out, and next week they're actually going to send a copy to every practice. So you will get it by next week at some time. But if you don't, contact your LMC because they've already got it.
Hi, sorry, just slightly concerned about the confidentiality issue, because as you say, I mean, that really does hit hard. Are we able, if they're coming to visit, to put notices up to patients to say that they could opt out in some way if they don't want people to have access?
No. Their legislation overrules anything else. And that's why the GPC's got so involved with this. And in fact, they must have had this so many times, because when they come in and they show you their badge, on the back of it is that bit of legislation that actually states that they can look at records. They don't take anything away, and they don't ever write down any names. But they will look to, but they will only look with justification. For instance, they spoke to one GP about child protection and about what sort of thing they had in place. And then they said, can you think of a child in your practice with a child protection flag on? And they said yes. And she said, show me. And it was for that particular purpose. And he said, there it is. He blocked out the top anyway. They weren't interested. They're not interested in the names. They were interested to see how it had been documented and whether it was on other families' records and things like that.
So you could sort of block out the header that gives the name?
You can. Yes, you can. But not for your staff, because it'd be quite difficult.
Thank you. Carole, with regard to the inspection, the person who comes, do you know if they're going to do a geographical area? So that, for instance, will you have one person doing Bedfordshire and one person doing Hertfordshire, or what?
They have teams. So they have various teams. So they have a team for the South West, they have a team for the South Central, they have a team for East Midlands and things like that. So I don't know what their actual cut-off points are, but they actually have a team that covers a given area, and then they look after everything in that area in terms of nursing home, care homes, GPs, dentists and everything else. So yes, they stay within a geographical location, but I couldn't tell you how big or small that is. I just know that they're in teams.
Are there any practices in the pilot which were really bad that they gave them a notice saying you're going to get
No, and they have said, and they said at the feedback, they were absolutely amazed at the quality and the standard of general medical practice. Think about it, 2 years ago they did the dentists. Now, come on. Dentists know nothing. They don't have QOF. They've never been monitored. They really had a hard time. The dentists had a hard time. CQC had a hard time. They were absolutely delighted to look at medical practice. There was the odd one that got a bit of, we don't find it, well, let me give you an example. We went into a dispensing practice in a rural area, and first of all, the inspector had never come across a dispensing practice, so that was quite interesting, trying to explain what that meant. And then we were in the dispensary in the sort of late afternoon when the post van turned up and came in and went, all right, Mabel, and took all the bags of prescriptions off the shelves, put them in his van. And the inspector looked at me, and I'm trying to look nonchalant like it's a daily occurrence. And she went, is that normal? So I said to the postman, where are you going? Well, he said, some of our old people can't get up the hill. I take it all down to the post office, and when they come in for the pension, they collect the prescription. Non-compliant, unfortunately, but she did enjoy it. The inspector quite enjoyed that. So they did get a non-compliance and were told that that process had to stop. And actually, the practice were thrilled because they didn't like it either, and they've been trying to stop it for years, and the patients had pressure groups and things. So the fact that CQC is saying, no, can't be done. But no, they are really... They only closed down 2 dental practices in the whole of the country. Now, I used to be a dental lead for a PCT, and I would have closed down 6 in my area. Not using gloves, all sorts of things. And one of them was a fire thing, and they put all that right, and they're reopened. So they are not expecting any GP practice to fail.
Hello there. Could you just confirm again when the fees are going to be confirmed? I know you said it's in consultation at the moment. Do we know roughly when in the year, next year, when it may be confirmed? And if this is an annual fee, again, do we have any appeal about, challenging that other than leaving comments on the website?
As far as we're aware, the consultation closes, it's either, do you know, off the top of my head, I can't remember if it's mid-December or mid-January. We will know in January, I think, what those fees are going to be, and then they will come in from April 13. So it'll be an annual fee from April 13. Once they've decided, there's going to be no appeal. Our only route is for the GPC to keep badgering away to say either this has got to come into the global sum or the Treasury's got to pay it in some way, but I wouldn't hold your breath.
This is such a critical issue that I've allowed Carole to go on way beyond the time we allocated for her. It's not your fault at all, Carole. I think the audience are engaged. But we are going to end up with a question and answer period. And I'm sure there are other questions. Simon has agreed to stay to be questioned about employment law. Andrew Tarry's at the back about anything you might like to ask about PCT. So I'm going to close this bit down at this point. Thank you very much.